Start. Okay, good evening, everyone, and welcome to this World Parkinson's Day webinar on Parkinson's disease and to raise awareness and answer all your questions and doubts. I think we have a galaxy of speakers tonight, and very fortunate to have this collection of speakers with us. So I think I would welcome all the speakers who have joined here already, and I would, to start with, like to invite the president of the MDSI, Dr. Asha Kishore, madam, to say a few words and kick off proceedings.
Thank you, Pankaj. Good evening to all, and a warm welcome to this webinar organized by the Movement Disorder Society of India. This is as part of the celebration of World Parkinson's Day, which actually falls on April 11th, but is not confined to that day and can be, and the mission and the vision of holding the World Parkinson's Day celebration can be conducted throughout the month and even throughout the year. So several events have been organized by neurologists and movement disorder specialists across the country in their respective institutions or in the local societies. But the Movement Disorder Society every year conducts this special webinar for the sake of improving the health awareness and educating the public, the patients, the caregivers, and even health professionals on what is happening in the field of Parkinson's disease, what is Parkinson's disease, how it is treated medically, surgically, what are the risk factors, what causes it, how can one take care of a patient with Parkinson's disease, what is in store for future, how can we improve the quality of their life, how can we assist them in their everyday life. So there are several aspects of Parkinson's disease that are updated every year with the new information that comes in. So every year we hold this webinar in order to update interested health professionals as well as a wide array of patients from across the country and their families and caregivers on what's happening in this field. So today we have Movement Disorder Society is a professional organization which has neurologists, particularly those who are interested in the field of Parkinson's disease and movement disorders, as well as people who are in allied specialties like movement disorder functional neurosurgeons, psychiatrists, physiotherapists, occupational therapists, neuropsychologists, and such people who, as a team, work together for the improvement of quality of life for Parkinson's disease patients. So we have today a galaxy of specialists who are working in this field, who are experts in this field, and who see large numbers of Parkinson's disease patients every day for several years in their career. And they are here to give the updates on what's Parkinson's disease, various aspects of Parkinson's disease, as well as hold panel discussions so that questions can be raised and responded to by these experts in this field. With these words of introduction, I'd like to declare our webinar as open and the processes can begin now. Thank you.
Thank you, ma'am. Again, I would like to welcome other speakers who have joined. I think the first two talks are on the motor symptoms of Parkinson's by Dr. Rishish Kumar, and the next talk is the non-motor symptoms by Dr. Rukmini Mrudula, who has joined also. So welcome. I would like to now invite Dr. Sumit Singh to be the chairperson for the next two talks. So Dr. Sumit Singh, please go ahead.
Yeah, good evening. It's indeed a very important day today in terms of dissipating knowledge about Parkinson's disease. The day is commemorated all across the world as the World Parkinson's Day on 11th. But as Dr. Asha just now told, it's just not limited to those areas. Now, Parkinson's, we all know, has several components to its symptomatology. Some of them are physically evident, some of them are not physically evident. So the ones which are physically evident, like the motor symptoms, the tremors, the rigidity, the postural instability, the bradykinesia. So these are the ones which trouble the patient in the initial stages of the disease. And to deliberate on this, we have Dr. Rishikesh Kumar, who is the head of the department and a well-known movement disorder specialist at the Institute of Neurosciences, Kolkata. Dr. Rishikesh, kindly let us know something about these things. Thank you.
Thank you. Let me share the screen. Thank you very much, President of MDSI. And sorry, am I audible?
Yes, you are.
Okay. Once again, thank you very much, President of MDSI, and thank you, MDSI, for this initiative. And thank you, Sumit Singh, for a wonderful introduction. We talk about motor symptom of Parkinson's disease, and these are the symptoms which you can see from outside in general. And there happened to be a gentleman known as James Parkinson's more than 200 years back. And he relied a lot upon motor symptom when he wrote his book, Essay on Shaking Palsy. And he used to stay on this first floor of this building, that is 1 Horton Square, which is, this picture is about 1812. And this is what it's right now. Sitting on the first floor, he used to see people walking around. He used to see people's motor symptoms, and he wrote a wonderful book known as Essay on Shaking Palsy. The cartoons are made from William Gower later, but this is the first page of the book. And he wrote wonderfully about almost all the motor features and many of the non-motor features, which we still rely upon. So these are the symptoms which are due to movements, related to movements. Either it can be slow or it can be excess movement. So motor means movement. So either slow movement or excess movement. And in Parkinson's, both we can see. So I'll start with very practical thing. Many times the patient comes to us that I have Parkinson's and they have only tremor. So in public, in general public, sometimes tremor is translated as Parkinson's disease. So I like to tell everybody that tremor is not Parkinson's disease. Tremor is a symptom of Parkinson's disease, but in majority, they happens in some other causes, which we'll talk about. In majority patient tremor, that means shaking, is not because of Parkinson's. Anxiety is one of the common cause. Essential tremor, which is very common, 5% of general population has tremor, that's common cause. Thyroid dysfunction, some medication, that is tremor cause. So tremor always is not Parkinson's disease. So what type of tremor is Parkinson's disease? If somebody in your neighborhood, is somebody in your relative, you see such tremor, most likely Parkinson's disease. What is this tremor? More during rest and not during action. When the patient stresses the hand, it's not there, but during rest, if the patient has tremor, that is most likely Parkinson's disease. And this tremor, as you see, one side more than the other side. So two component here, rest tremor, and one side more than the other side, either unilateral or asymmetrical. That is tremor of Parkinson's disease. One more thing you see, this tremor is slow, not very fast. Slow tremor looks like as if the person is pill rolling. So that tremor is most likely Parkinson's disease. So this tremor, if you have rest tremor, one side more than the other side, then it indicates Parkinson's and not all types of tremor, right? In other type like essential tremor, patient have more of action tremor and not rest tremor. But that doesn't mean that Parkinson's won't have action tremor. Look at this patient. You can see the patient has action tremor. So what qualifies as Parkinson's disease, when you see the patient a little longer, he has rest tremor also. So rest tremor is more prominent than the action tremor. Rest tremor is putting the hand in the hand on the lap. So if somebody has action tremor with rest tremor is more prominent, one side more than the other side, and coarse means not very fast, means coarse tremor, that again favors Parkinson's disease. And sometimes what happens, you have put the hand in the rest, you put hand outside, and there's a gap in between. And in medical word, we call as re-emergence. If the tremor re-emerges, again, one side more than the other side, most likely Parkinson's disease. You can see this gentleman has rest tremor. He brings the arms out, tremor is gone completely. To come back again after some time, again, one side more than the other side, again, coarse tremor. Coarse means not very fine, not very rapid. That's most likely Parkinson's disease. But this type of tremor, this is not Parkinson's. When the patient has no rest tremor, but only on action tremor, and it increases more on the target. This is not Parkinson's tremor. So last 4 videos were to impress upon that tremor can be seen in Parkinson's disease, but all tremors are not Parkinson's disease. There should be rest tremor, one side more than the other side, and little coarse tremor. So is tremor necessary for the diagnosis? Emphasizing again, because without tremor, patients sometimes have difficulty to accept that they have Parkinson's disease. And the answer will be no, tremor is not necessary. When you see the criteria, which was given by UK Brain Bank criteria, they saw the brain bank of many patients of Parkinson's, over 16 patients of Parkinson's disease, and they found that tremor was not constant in all. Slowness was constant. So slowness plus any of the following, rest tremor, stiffness, rigidity, and some walking difficulty, walking imbalance, that constitute Parkinson's disease. So you can see that somebody can have slowness, only walking difficulty, that's Parkinson's disease, without tremor. So this is the criteria which we use in clinics. And I would say that when you follow this, even a general public can diagnose Parkinson's disease easily. How slowness present to us? Usual story that it takes more time to perform the same activity, which I used to do earlier very easily. But problem is that Parkinson's generally, in majority of cases, in elderly disease, so they all blame to the age. Because I'm aging, because my father is aging, he has become slow, and that explains everything. So that we have to understand that aging is fine. People can become slow, but slowness can be because of Parkinson's also, and we have to see very clearly how to examine that and see if you have such patient who's so slow. Don't blame aging. Of course, aging can slow down a bit, but you can see that patient is slow, turns around with a lot of effort, stoop forward, walk slowly. This is slowness, what we call as bradykinesia. But if somebody has to measure that, this is the way to measure. We ask the person to open, close fingers as fast as possible and as wide as possible. What happens when we do that? There's some speed, and it maintains the speed and maintains the width, that means amplitude. If in due course of time, speed decreases or width decreases, we call as this is bradykinesia. So slowness is very important. Bradykinesia is very important because you saw that was a key feature. And without that, we cannot diagnose Parkinson's disease. And I'll impress upon that slowness can be, bradykinesia can be seen by any gentleman who has reasonable IQ. So this is bradykinesia for you. So bradykinesia is very important. You can see that he started wide and sleep. He's going slow now. He's going slow. So that is bradykinesia. Other manifestation of slowness, when you start writing in Parkinson's patient, and this can be the first symptom in office goers because they complain that their writing has become worse, deteriorated. The first letter starts big and gradually it tapers off. Gradually it becomes smaller and smaller and smaller. That we call as micrographia. So slowness, one feature is micrographia, which can be seen in writing. Decreased arm swing, the automatic movements of the patient, that decreases. You can see this gentleman, he's walking. You see the left arm is swinging well, but right arm is not swinging, and very minimally swinging. This again is a feature of a slowness or bradykinesia. So bradykinesia can have many phases. You saw generalized slowness. You saw that tap was slow. You saw micrographia, means writing was smaller, and you saw that arm swing was less on the right side. Moving on. Okay, so this is a composite picture. When you see, look at his left hand has rest tremor. Look at both hands, arm swing is gone. Look at his walking is very, very difficult. He almost cannot walk at all, or walks very slowly. So his speed, walking speed has decreased. So that we talked about slowness, we talked about tremor. You can see gait also, walking speed has decreased. And in Parkinson's disease, apart from walking speed, one more thing is to keep an eye on the stance width. When you stand up when you walk, normally in Parkinson's disease, the distance between the 2 feet is not too wide. Too wide means some other disease. The disease of back of brain known as cerebellum, disease of blood vessels known as vascular. But in Parkinson's disease, you can see the width is not too wide between the 2 feet. So stance base is narrow as compared to this case where width is wide. And this case, you can see that arm swing is also well preserved. So this is not Parkinson's disease. This is because of some small stroke that has happened. And this is true Parkinson's disease where stance width is narrow and one arm swing is less. All right. Then among walking difficulty, the word we use is freezing of gait. That happens quite frequently. In advanced Parkinson's disease, moderate or advanced Parkinson's disease, and treatment is very difficult. But what do we mean by freezing? Freezing is simple. Freezing means freezes. When they try to walk, freezes. But that can happen in various phases of walking. At this patient, he has freezing when he tries to start walking. So that we call as start freezing or start hesitation. Some gentlemen, they have good walking. You can see that he's walking well. But when they have to negotiate that turn, they have a lot of difficulty. They freeze at one place. They take a lot of many steps to take that. So that again is feature of Parkinson's disease. You can see that he took six or 8 steps and then he walked normally. So that means we have to see patient when walking, turning around also we have to see the patient and we can find freezing at that. And one more word is fascination. That's quite devastating for patient, because freezing, yes, they stop. But fascination, what happens? At one point of walking, they become very fast, so fast that body doesn't keep, they don't keep up, and body falls forward. That's fascination. You can see in this walking, but small length of each steps, and suddenly it's getting faster, and the whole body falls forward. So one of the cause of fall is fascination, which can be seen with freezing many a times. Now, apart what we saw was walking stance difficulty, walking difficulty, but walking difficulty slow is okay. Balance problem is not okay. Whereas if balance problem is there, the chance of more fall, and fall can be again devastating. And sometimes subtle balance difficulty can be seen by what we call as pull test. We stand behind the patient, we give small pull, we explain the patient what is expected. Small pull. Generally, after 2-3 steps, the patient should recover, but over here you can see he took 4 or 5 steps. That can be early sign of balance difficulty. Coming to rigidity. So we talked about walking difficulty, we talked about tremor, we talked about slowness, and finally is rigidity, that is stiffness. This is a symptom which you cannot see, we may not see from outside. Patient explains to you that I'm very rigid on one side, I'm so rigid that stiff, it looks painful. But can we test rigidity? In that case, when you have to test rigidity, we ask the patient to release as loose as possible and do all, let's say in the wrist, in all the angles, we see passive movement, and we can find resistance, that resistance rigidity. But sometimes this can be very extreme, like this patient. She missed the dose of levodopa and she became so stiff that whole body is like a wood. And I removed the pillow, and still, because of rigidity, she was above the bed. So that's extreme case of rigidity. So we saw that in walking Parkinson disease, patient can stoop forward, decreased arm swing, short stride length, less clearing from the ground, shuffle while walking. But apart from walking, many times we see the patient takes a few steps to get up from the chair. They take few attempts to get up from the chair. And that itself can be part of Parkinson disease. Levodopa has been a boon for the patient. We all know this is after levodopa, this is pre-levodopa, same day. You can see that life changes with one small tablet. And that's the honeymoon period when patient, they do well for say 4 or 5 hours after one dose of levodopa, but that doesn't last long. And after some time, motor fluctuation develops where patient has on-off phenomena. After levodopa, they're good for say 2-3 hours and suddenly become off. And at the same time, they have dyskinesia. Means after levodopa, they are good, they can walk, but with a lot of dancing movements. And this is a picture given by Dr. Prashant. You can see that initially you're in the green zone, means good zone. After a while, slightly higher dose, you're in the red zone, that is the dyskinesia zone. Slightly lower dose, you're in the gray zone, that means slow zone. So they go from slow zone to somewhat better zone, and then again dyskinesia zone. And dyskinesia can be mild, subtle. This patient has mild dyskinesia, and this dyskinesia, patient don't bother about that because they're happy with the on phase. Sometimes family members bother. So again, a message is that if you have mild dyskinesia, don't worry about that. Dyskinesia is part of treatment, part of Parkinson's disease, and there's no need to overtreat them. But bad dyskinesia, again, this is an extreme case. This needs treatment. Levodopa-induced dyskinesia, this needs treatment. Treatment by reducing the dose of levodopa or giving some other medication, and sometimes DPSOs. So the dyskinesia, the very spectrum of dyskinesia, again part of motor syndrome, which is drug induced rather than real because of medication. Now, dyskinesia can be because of high dose or on the peak of dose, can be in the off of the dose. The doctor's role is to define or to identify dyskinesia at what phase, and we arrange the medication accordingly, which will be discussed by Dr. Pankaj later on. When we think of dyskinesia or on-off, we feel that levodopa is the culprit, levodopa is the bad boy, but keep in mind the levodopa gives good quality of life. And one study was done by one of my friend in Ghaga, Patrick Adzai. This is a scientific graph, but I like to tell you that in Ghanaian population, when Ghanaian population, when the medicine was started late, that did not give long good phase, long honeymoon. That was very short. You can see deep blue, very short honeymoon. Started early in Italian population, it gave a long honeymoon. So if you save levodopa for a long time, that doesn't mean that the good on will be for a long time. Good on will be for short time and dyskinesia appear again. So that means medication is not only the culprit, it also the tissues there, which in due course of time in advanced Parkinson, that changes its conformation and that can cause dyskinesia. One last point that we have many patients, they generally they do well for a long time and suddenly they feel that everything has gone down, motor symptom has gone down. In that case, we suggest the patient, you find many times, they check the medication, whether you missed, whether the timing with the food was altered, cut the clutter, whether you added a new medication for your gastric like levosulfide or for some psychiatric symptoms, or sometimes infection also can alter motor symptoms and electrolyte balance. So sudden deterioration generally doesn't happen in Parkinson's. We have to look for other causes for sudden deterioration, and that way we can treat. So thank you very much. And there's an overview of motor syndrome. And after that, my colleague will be talking about non-motor, and we'll talk about it. Thank you. Thank you.
Thank you, Dr. Rishi, for an excellent overview of the motor symptoms. And I think now we will move on to the next talk. So Dr. Sumit, maybe you can say, invite Dr. Mridula.
Yeah,
Sumi.
Dr. Mridula is from Hyderabad, and she is presently working as a senior consultant of neurology and a movement disorder specialist at City Neuro Center in Hyderabad. She's a movement disorder specialist with the keen interest in Parkinson's disease, particularly deep brain stimulation and other aspects of management of Parkinson's. So she would be enlightening us about non-motor symptoms in Parkinson's disease.
Thank you, sir. And am I audible? Thank you, MDSI, for giving me this opportunity. We know that Parkinson's disease is much more than just motor symptoms. There are a lot of non-motor aspects. The reason why it is called as non-motor means that it is not seen very easily, because it is not it is a lot of things are felt, or you have to ask these questions. But this is a busy slide where you can see that not just the motor or non-motor, you have to look at the other comorbidities also for a Parkinson's disease patient. Now, traditionally, actually, there has been a divide between motor and non-motor, but it's not actually true. They're just the two sides of the coin. Both of them happen together. The non-motor, as the disease progresses, becomes very, very prominent and can cause a lot of impairment in the quality of life. So these are the most important elements in defining the quality of life in patients with Parkinson's disease, and this has to be elicited, because a lot of times people don't come up with it. Now, if you want to classify the non-motor symptoms, you can give it into 4 major groups, like neuropsychiatric complications, anxiety, depression. This may be a part of the disease process itself. It can start even before the disease onset. You can have memory disturbances, which can come later on in the disease. You can have features like hallucinations, where people see somebody, or they have some kind of delusions, where they have delusions of infidelity. It's very, very common and commonly seen with patients with Parkinson's disease, especially those who are on high dose of dopaminergic medication. You can have something called as impulse control disorders, where they are very impulsive in terms of taking decisions. They may have a lot of gambling issues. So there is a problem with the disconnect between the reward and the loss system in the brain, and so they can become more and more, people may gamble, they may eat more, they may spend more, they may have hypersexuality, they may have, so along with these things, if the patient has got hallucinations, they can have a lot of delusions. Delusions means that they have false belief. They can have delusions of people with infidelity. A lot of older patients who are on multiple medication come up with this kind of a symptom, and a lot of times they won't come across to you because they're quite ashamed of discussing these aspects. So it's important to ask about them. Autonomic disturbances again can be divided into gastrointestinal constipation is very common, cyalorrhea or dyspepsia, urinary disturbances, especially getting up very frequently in the night. Orthostatic hypotension, patients can just develop some kind of pain when they get up, or giddiness when they get up, and that's because the BP drops when they stand up. It's quite common in the later stages of the Parkinson's disease. Excessive sweating, you can see this picture of a patient who's completely drenched. He used to carry a tablet of levodopa, and that tablet also used to get drenched with this kind of sweating. These kind of disturbances can fluctuate again in the on and off. Dr. Rishikesh has just spoken about the on and off phenomena. So they may be better in the on state and worse in the off state. Sleep disturbances. There's sleep disturbances like REM behavioral sleep disorders, where patients can shout in their sleep, move around in the sleep, or restless leg syndrome, where they have pain in their leg. which makes them get up and walk. So again, these are symptoms which people don't consider it to be significant unless you ask them, and they can start before the disease onset itself. People can have difficulty in sleeping not just because of the sleep disturbances. They may be because of they are stiff, they are more off, or they may be having one of these two conditions like RBD or RLS. Because there's more, they have insomnia. Patients can tend to have excessive daytime somnolence. They can sleep a lot in the morning time. This is also aggravated by a lot of medications, especially dopamine agonists. So this is again something, if they are sitting and suddenly you go off to sleep and you're talking, I think it is, you have to consider the excessive daytime somnolence. You have to decide and modify your medication. Other aspects like loss of olfaction, pain and sensory complaints can happen. A lot of patients have pain, especially in their off state, which improves in their onset. And a lot of them have back pain, they have knee pain, they have generalized body aches. They tend to go to the orthopedic surgeons. They can have shoulder pain, they can have shoulder periarthritis. These are all features which actually are predictors of Parkinson's disease, and they actually respond to medications which are given for Parkinson's disease. So a lot of them actually visit orthopedic surgeons, they visit neurosurgeons, thinking that they are all other causes of the pain rather than Parkinson's disease itself. Now, how does the NMS evolve? It can evolve through the disease process. It can start much before the disease, and then it can worse. Some of the NMSs can progress beyond. So constipation, urinary urgency, RBD or smell, all hyposmia can all happen before. Erectile dysfunction, cognitive abnormality, pain can start with the Parkinson's disease, can progress with the Parkinson's disease. Non-motor fluctuations, sleep disturbances, the impulse control disorders, cognitive impairment, hallucinations happens once the patients become more and more advanced in the disease. Age also makes a difference in the disease process. So if you have a younger patient who's staying, for a longer duration, cognitive impairment doesn't happen so commonly as much as an older patient who actually starts to develop cognitive impairment much earlier in the disease process. So both medication as well as the disease as well as the age makes a difference in the non-motor symptoms. Now there are prodromal non-motor symptoms, and you can actually have a predictor for diagnosing preclinical Parkinson's disease. This is still, there is a scoring which can be done. So in that scoring, what has been seen is RBD, which is polysomnographically proven. So not just by the history, but you do a polysomnography, find that the patient has got a REM sleep behavioral disorder. What we mean by REM sleep behavioral disorder is that the patient, normally in REM sleep, patient should be atonic, means it should not be moving at all. Their muscles and all should be loose. But in case of patients with Parkinson's disease, there is a disconnect. So they start to have movement, they start to talk in their sleep, they start to move around. Sometimes they can hit their spouses because they think that they are enacting their dream. It's called as a dream enactment behavior. They can fall over from the bed, they can injure themselves. And this RBD has got the most common, the most highest predictor of developing Parkinson's disease, especially if it is associated with olfactory loss. So if you have a combination of RBD and olfactory loss, there's a high chance that the person can develop Parkinson's disease. We really don't have a medication to prevent the progression to Parkinson's disease right now, but it is important to identify them, because staying physically active and having a high exercise regimen for these patients can actually probably slow down the progression or slow down the onset of the Parkinson's disease. Constipation can also is another feature, the third common possibility. The others are all has some amount of effect, but the main predominant non-motor symptoms are RBD as well as olfactory loss. In combination, olfactory loss should be not related to any disease before. So somebody has got a bad cold, somebody had an injury to the nose, they have olfactory loss, that has got nothing to do with Parkinson's disease. So COVID-related olfactory loss also probably does not have any major relation to Parkinson's disease. A lot of people have not got back their smell after COVID, but I think that may not be a prodromal symptom, as right now we don't have any clue like that. So as you see the disease progression, you can have the non-motor symptoms can progress. Now, does taking levodopa make a difference, or does the geographical location make a difference on what kind of non-motor symptoms you happen? Yes, there is a difference. In India and Japan, or in the Asian continent, this is a non-motor international longitudinal study, or a NIL study, which is ongoing. If you look at the Indian population, we have a predominant sleep fatigue combination which are a little higher, and mood and apathy is much more common. Our non-motor symptoms in general, the patients suffering with the number of non-motor symptoms that they have is much lesser compared to Europe and US. If you see the overall non-motor symptoms scale, and the severity is also lesser. Urinary symptoms, sexual symptoms are much lesser in our patients. Pain is also not that common as much as is seen in Europe and US. If you look at whether the patient receiving levodopa or not levodopa, just like the effect on the dyskinesias, it didn't make a difference on whether the patient received levodopa or other medication. Most of the non-motor symptoms seem to be the same. These are not the drug-related non-motor symptoms like ICD, but apart from that, the other symptoms all seem to be the same whether they received medication or they did not receive medication. Now, just a few examples of what genetics may differ and may cause a difference in the mutation. This is a patient with a Parkin mutation, very young onset patient with Parkinson's disease, autosomal recessive because of a higher yield of consanguinity, and this is quite common gene which we see in Indian population. This is a patient who has a leg rising dystonia who underwent DBS and is fine. So why am I just showing a patient with a Parkin mutation? Because genes can make a difference on the non-motor symptoms. Just to give a very brief overview, if you have a alpha-synuclein mutation, which is very uncommon in the Indian population, it's a very uncommon mutation in general, but that they can have very severe olfactory loss, cognitive decline, severe autonomic disturbances, as well as psychotic symptoms. On the other hand, the LRRK2 mutation, which is actually quite commonly seen in the adult population of Parkinson's disease, as well as the VPS35, that is the PARC17, they have lesser non-motor symptoms compared to the ones who don't have genetic abnormality. Parkin mutation, the one that we saw, has lesser olfactory loss. They are actually cognitively well preserved. They tend to have more impulse control disorder. So when you're having a Parkin gene mutation, if you have a Parkin gene mutation, you have to be a little bit more careful in starting them on dopamine agonists because they are more prone to developing impulse control disorders. Now, similarly, if you have a patient with PINK1, which is a mitochondrial gene, again, this is also an autosomal recessive disorder, which we see commonly in India. You can have psychiatric abnormalities, especially anxiety and depression are common. Hyposmia is also common. Cognitive impairment is not so common. DJ1 mutation can have more prominent cognitive decline as well as depression and anxiety. GBA mutation, which is actually again a common mutation that we see in Indian population, they can have more severe cognitive impairment, anxiety, depression, autonomic dysfunction, REM sleep behavior disorder. This group of patients tend to progress more rapidly and they have more severe both motor as well as non-motor symptoms. Why is it important to know the GBA mutation? If you want to do surgery or if you want to do an advanced therapy, you should know that they have tendency to developing cognitive impairment, especially with the deep brain stimulation of the subthalamic nuclei. So this is one patient who had undergone DBS in Bangur Institute of Neurosciences in Kolkata. So the whole discussion is whether you should take up GPI because they are very young onset PD patients. The response to DBS is not as good as the rest of the Parkinson's disease patient, but they require the DBS because they tend to progress also more early. But maybe you can use another site like Globus Pallidus Interna. Now, if you want to actually classify the Parkinson's disease as non-motor, based on non-motor, there are a lot of subtypes which has been now described. There are 9 subtypes which has been described where people can present with apathy or the inability to do any activity, they become more dull, or they can have depression or anxiety, they can have cognitive impairment, more autonomic disturbances, fatigue is one subgroup, pain or sleep disturbances. Now, there are a lot of work which is going on and you can see that you can divide it into a combination of tremor, rigidity along with the multiple non-motor aspects, and it looks very complicated. But the reason why it is done is because you want to look at the pathophysiology or the underlying cause of what is causing the non-motor abnormality. Now we know that most of the motor symptoms in Parkinson's disease is because of the drop in the dopamine pathway. So the dopamine reduction is causing most of the disturbances. Whereas when you talk about non-motor, it is not just pure dopamine, though dopamine also plays a role, especially in things like pain, apathy or depression. Dopamine does make an impact. But if you have patients who have got orthostatic hypotension where the BP drops, it is more likely that there are noradrenergic pathways involved. So because you know that this is the pathway which is involved, so you know the noradrenergic system is involved, the medication also becomes more easily, you can choose the medication. So you would give them medications with the sympathomimetics. Especially again, if you have a patient who has got a cholinergic component or the acetylcholine component in the brain comes down, they can have gait disturbances as well as they can have cognitive impairment. So memory disturbances can happen. So when you have these kind of features, the treatment becomes a little bit more simplified because you can give tablets which can increase the cholinergic level in the brain, and you should avoid giving them anticholinergic. The fatigue, depression and sleep disturbances are usually secondary to a serotonergic component. So you can increase the serotonergic content in the brain. We are still exploring exactly how Parkinson's disease affects all of the, all these symptoms. It is not, we don't have an exact answer to it, but we are going nearer and nearer to finding out what chemical changes are probably causing these non-motor symptoms. So based on that, the treatment can be given. So how do you treat it? See, any diseases, I'm just talking about neuropsychiatric disturbance, but any of the non-motor symptoms, it's always important to look for the underlying cause. It's not necessary that all non-motor symptoms are caused by Parkinson's disease, but you have to ask them. And there are a lot of questionnaires which are available. The MDS has got a non-motor symptom questionnaire. There is already an NMSS questionnaire. So you need to ask them the questions regarding their neuropsychiatric manifestation, the autonomic disturbances, the sleep disturbances, or the pain and management. Unless you ask them, they are not going to, patients are not going to come across and tell them. And unless they are aware that these can be a part of the Parkinson's disease, they are not going to tell us about it. So you look for after finding out the cause, you look for the cause. There can be a lot of combination of medication which may be increasing these non-motor symptoms. So you have to stop these medications, especially if you have neuropsychiatric disturbances, look for anticholinergics, titrate the dopaminergic medication and the other medication, and then you look for nutrition deficiencies. Like Parkinson's disease causes lesser absorption of vitamin B12. A lot of times cognitive impairment may be secondary to an additional B12 component. It's not just that, it's not just the cognitive impairment in PD. So it is important to treat the underlying other deficiencies that they have. There are specific therapies. You give antidepressants. Mirtazapine is one of the commonest drugs which are given. Antipsychotics, if the patient has got a lot of hallucinations and delusions, quetiapine is commonly given. Pimavanserin is available, 34 milligram. It's just coming in the market. It was available for a short period. Again, it is not available currently, but I think it will be again coming up in the market. If you have a patient with dementia, cognitive anticholinesterase inhibitors, even with people who have got gait disturbances, you can give them, like donepezil or rivastigmine. If a patient comes with impulse control disorder, this is just one patient that I wanted to show because you can, they're doing the on and off, but what you can see is the policeman there because he was arrested because of an impulse control disorder. He had a hypersexuality, he molested a woman and then he was put in jail. So this is because of the Parkinson's disease and because he himself had an insight that that he is not able to stop thinking in that terms. He underwent deep brain stimulation because we stopped the dopamine agonist and he's much better. Sometimes even after stopping of the dopamine agonist, many of the patients may not improve. You can try some amount of mood enhancers or mood stabilizers like sodium valproate. Sometimes an antipsychotic can help in some patients on a lower dose. Quetiapine can be given for patients with impulse control disorders. If you have autonomic disturbances, especially if you have orthostatic hypotension, make sure that they have a lot of non-pharmacological measures that are done. Head up position is very important. A lot of people think that if you have BP is getting down, when you are standing up, your legs should be up in the bed. That is actually the exact opposite of what you should be doing in a patient with Parkinson's disease with orthostatic hypotension. There are two reasons. One is when you are putting the patient up in the head up position, there is a little bit of water retention, so it improves the orthostatic hypotension. It also reduces the supine hypertension, that is increase in the BP on lying down, which happens when the patients lie down. You can give you can fragment the meals. Meals can worsen the hypotension, so you make sure that they're having smaller meals and more frequent meals. Medications like fluorocortisone and midodrine can be given for patients who have got severe orthostatic hypotension. If there's a lot of increased salivation, you can increase the dopaminergic medication. Sometimes it helps. Glycopyrrolate, botulinum toxin can be given. Again, glycopyrrolate is an anticholinergic medication, can worsen the memory disturbances, so you have to be a little careful. constipation, diet modification, increasing the fiber content. This should be started, I think, immediately as soon as the patient is diagnosed to have Parkinson's disease, so that they have that habit of having a proper diet for preventing constipation or improving constipation. Drugs increasing fiber volume or improving motility can be given. Ruclopride is quite commonly used, but again, these can worsen the constipation on a long-term basis. They can also worsen cognitive impairment on a long-term basis. Autonomic disturbances again are individualized. You need to restrict the fluid in the morning times if they have a lot of nocturia, which is the most common symptom. You can give a lot of medication like alpha adrenoceptor blockers, muscarinic agonists. Again, these have a lot of side effects causing orthostatic hypertension or cognitive impairment. I think now the most common drug that is given is mirabegron, which is a beta-3 adrenoceptor agonist. Sacral nerve neuromodulation is a surgical procedure which can be done for treating patients with Parkinson's disease with autonomic symptoms. So if you're looking for sleep abnormality, you have to look for the cause of the sleep disturbances. If you have RLS, there are some medications which can be used for RLS. Again, for a patient who's got a restless leg syndrome, means that they have pain in the leg and they want to get up, they're not able to lie down for a short period. This restless leg syndrome worsens in the evening. You should also look for whether the patients are on any antidepressant. Sometimes the antidepressant can worsen the restless leg syndrome, especially all the SSRIs can worsen the RLS. So make sure that the medicines are titrated again. If the patient has got REM sleep behavioral disorder, melatonin or clonazepam can be given. If it is not possible, maybe it is better for the patient to lie on the ground because they may tend to fall down and injure themselves. If there is sleep disturbances, can give them, proper sleep environment and hygiene should be important. If the patient is stiff, rigid, the motor symptoms are worse in the night, dopamine can definitely be useful. If the patient has got a urinary urgency, nocturia, treat the nocturia, they will probably be better with insomnia. Zolpidem clonazepam can be given. If the patient has got a lot of excessive daytime somnolence, modafinil can be tried. Modafinil can be tried for fatigue also, though the benefit is not so common. What about the advanced therapies? The advanced therapies make a difference in the in the improvement or the worsening of the non-motor symptoms. Some of the non-motor symptoms like pain, the nocturia can improve with DBS, as well as if you have sleep and fatigue, which can improve with the intrajejunal levodopa infusion. Apomorphine infusion can improve the restless leg syndrome, mood, cognition, perceptual problems, or the attention and memory. So these are some things which do happen. There is some benefit in terms of the advanced therapies, but based on both the motor and the non-motor, the advanced therapies can be actually titrated according to the patient. So it is like every patient has to be treated individually because they have a combination of different motor and non-motor symptoms. So based on it, and based on their lifestyle, based on what kind of comorbidities that they have, based on what kind of jobs that they do and what is their expectation, the treatment options has to be titrated to each and every patient. So thank you for your patient listening.
So thank you, Dr. Rukmini. I think that was an excellent overview of all the non-motor symptoms in Parkinson's. And I think for all our patients who are listening in and our other colleagues, I think it is common knowledge by now that Parkinson's, as has been mentioned by the speakers, is not only what we see physically or with tremor and rigidity or shaking. It is also so many other things that affect the mind, the thinking, and so many other things like sleep, pain, fatigue, and all the other non-motor things that are mentioned. All these really impact the quality of lives with Parkinson's. And I think it was an excellent overview by Dr. Rukmini. So there are a few questions, but I think we will take them at the end. And I would like to now welcome all the other panelists that joined. So for the panel discussions. So the remaining part of the webinar is in the form of two panel discussions. And the first one is on the etiology and risk factors of Parkinson's disease. And the panelists for this one are Dr. Bhaskar Ghosh from Kolkata, Dr. Charu Sankla from Mumbai, Dr. Prashant Elke from Bangalore, and Dr. Suvarit Dhome from Baroda, Gujarat. So the moderator will be my colleague, Dr. Jackie Ganguly, and from the Institute of Neurosciences, Kolkata. So I think Dr. Jackie, maybe you can start proceedings on the first panel discussion, etiology and risk factors of Parkinson's disease.
Thank you, Pankaj sir, and warm good evening to everyone. So it's my absolute privilege to welcome Dr. Bhaskar Ghosh sir, Senior Movement Disorder Specialist from Kolkata, Dr. Charulata Sankla ma'am, Movement Disorder Specialist from Hinduja Hospital, Mumbai, and Dr. Prashant LK sir from Movement Disorder Specialist from Bengaluru, and Dr. Shubharit Bhaumik, Movement Disorder Specialist from Vadodara, Gujarat. So we'll start the first panel discussion, and this will be mainly on the etiology and risk factor for Parkinson's disease. So here I will ask the question as if I am a Parkinson's disease patient. So I will ask on behalf of the Parkinson's disease patient and their caregivers, and they often ask those questions, they are in doubt, and so that let's discuss those questions first, we can help them. So my first question would be to Bhaskar Ghosh sir, and the question is, are there any environmental or occupational risk factor for Parkinson's disease?
Thank you, Dr. Jackie Ganguly. At the outset, I thank MDSI for giving me an opportunity to be a panelist in the discussion of Parkinson's disease. Now, there are several risk factors, rather environmental risk factors for development of Parkinson's disease. I will describe those which are mostly discussed or reported. First of all, I will say that living in urban or industrial area with high exposure to copper, manganese, and lead is an important risk factor. Exposure to air pollutants like nitrogen dioxide and fine particulate matters is also a risk factor. Exposure to hydrocarbon solvents, particularly trichloroethylene, high consumption of dairy products, and also high dietary intake of iron, especially in conjunction with manganese. There is also certain other risk factors like reduced level of dietary and sunlight-derived vitamin D, which I think is pretty common in India, but it has also been implicated as an risk factor. Now, living in rural areas and exposure to pesticides, use of well water, and farming and agricultural work has also been implicated as some environmental risk factors. But with that, I want a 1 minute time from Dr. Ganguly that I want to name some protective factors so that the patients of Parkinson's disease do not get disheartened. And among the important protective factors is smoking, which we do not advocate, but smoking has been shown to be a protective factor for Parkinson's disease. So also caffeine, exercise, and certain drugs like ibuprofen. And there is a question mark also use of statins, which many people take. So whether they can give some protective effect. Also some inhibitors of renin-angiotensin system like ARB, angiotensin receptor blocker drugs, which are used for blood pressure. They have also been implicated as protective. And another one or two is that glycolysis enhancing drugs like terazosin, doxazosin, or alfusin, which we use in case of prostatic hypertrophy. And the latest one is which has been implicated, not although proved, but there is a study going on that is GLP-1 receptor agonist, that is glucagon-like peptide agonist. So they can be protective. So there are certain risk factors and there is protective factors. So this way the things go on.
Thank you so much, sir. Thank you for explaining all these nice insights regarding both the risk factors and etiologies in the urban and the rural areas. Thank you, sir. So my next question is to Dr. Charulata, ma'am. Can Parkinson's disease develop from the side effect of some drugs?
Definitely. It's not the Parkinson's disease, but if the patients take the dopamine blocking agents, that means the agents that block the dopamine. So these are the ones which are used in treating the psychiatric illnesses. These are the drugs that are used to treat the vomiting. These are the drugs that are used to treat the vertigo-like symptoms. All these drugs can cause the dopamine depletion in the brain, and will mimic the symptoms of Parkinson's. Many times we believe that the drug-induced Parkinsonism is completely reversible, but these drugs can actually unmask the pre-existing Parkinson's disease and bring it out. So when we withdraw these drugs also, some of these patients may still have persistent Parkinson's symptoms. So these are the ones which I would be very careful while prescribing to the Parkinson's patient. So the Parkinson's disease remain in some of these patients as a permanent syndrome. And we do a scan called TODAT scan, which tells us whether it's a pure drug-induced Parkinson's disease or it is the kind of Parkinson's disease which has been unmasked by these particular drugs.
Thank you so much, ma'am. In our clinic, we many a time get this kind of patients who are taking this levosulpiride for a long time and developing Parkinsonism.
Correct.
And I think that's a common practice. And through this forum, we'd like to ask all our Parkinson patients and their caregivers who are listening the program, so be aware and don't take levosulpiride for a long time. That is commonly misused as a gastric medication. Okay. Thank you, ma'am. So
medication which is given by the family physician.
yeah.
So when asking the family physician for the treatment of the acidity, that time you should specifically say that you should not be giving me a dopamine blocking agent called Lezuride, because inadvertently this has been given to a lot of patients. And it comes with the additional symbol of L. So if you have any acidity tablet, which is Pantocid L, Omez L, so the minute you have that L in the acidity tablet, you should be very careful about this drug.
Absolutely, ma'am. Thank you. My next question is to Dr. Prashant, sir. Can Parkinson's disease develop after some viral infection like COVID? Recently, we had this pandemic and we got a lot of Parkinson patients asking these questions. So can you please enlighten us?
Yeah, hi. Thanks, Jackie. Thanks for the question. And at the outset, I'd like to thank for the Movement Disorder Society of India to taking up this lead to create awareness about Parkinson's disease across India. Coming to this question about can any viral infections or let us say the COVID which we had recently, can it possibly increase the risk of Parkinson's disease? There are two ways when we look into it, because whether an infection can directly cause a Parkinson's disease or can it create a situation and scenarios where Parkinson's disease, the risk of Parkinson's disease can occur. And most of this, what you can do is you can learn from what has happened in the previous years or the previous outbreaks of the large viral infections, what you have seen. I think all of us do well remember that about 100 years back when the Spanish flu had struck in 1916 and 17, a lot of people had left with so-called Parkinsonian type of a syndrome. And it almost took about 20 years, almost 2 decades before an association between that Spanish flu and the Parkinson's disease could have been established. And over the time, in last 100 years, there are a lot of other viral infections which has been shown to get associated with Parkinson's disease. Like it may be like West Nile virus infections or Japanese encephalitis, can cause or can be left with a sequelae. Now, coming specifically into this of COVID, whether COVID can cause a Parkinson's syndrome directly. We have seen a lot of patients during the COVID outbreak who had Parkinson's disease, had worsening of Parkinsonian syndrome, but there was no dramatic acute increase in the patients with Parkinson's disease. Yes, there are some patients who had developed Parkinson's disease or Parkinsonian-like disorders, and even we were able to show that some of the patients had loss of dopamine in the brain by doing this specialized, what we call it as functional imaging of the brain. But can it increase over the time? Even though directly it has not caused dramatic increase in number of Parkinson's disease in last 1 year or 2 years, I do feel that it may have an impact because Parkinson's disease is an aging related process, right? It's like your brain energy which is being utilized. And over the period of time, we know that Parkinson's disease occurs due to mitochondrial functioning loss, other neuronal cell loss, and people who had already a damage in this set of cells and they had a little bit of increased propensity to develop those type of issues can probably develop earlier onset symptoms. It's similar to like heart attacks and other things. People who have risk of heart attack and diabetes, let us say if they're going to develop in their 60s and 70s, if their quality of life was not good, stress levels were high, they may develop earlier in the time. And in that context, when you remember how COVID had happened, COVID had caused a lot of stress for it. Not only physical stress, there was a lot of biochemical stress, a lot of people who had increased CRPs, a lot of chemical changes were happening. And one of them was what we call it as angiotensin converting enzyme pathway, which was damaged. And many people had issues in regard to this. Only with time we can tell how the pattern of Parkinson disease will change. We may require another 5 years or 10 years or 15 years to see whether COVID per se has dramatically increased the number of patients with Parkinson disease. But as of now, probably I can tell that yes, viral infections can increase the potential risk of occurrence of Parkinson disease. And not only that, we can also tell that patients may be more predisposed. People who are already had a higher risk of developing Parkinson disease, now because of other stress of infections, other acute events, they are more predisposed. And down the time, we'll be in a much better position to tell that whether it was a direct association or an indirect association. But whatever is the cause, at this point of time, the current treatment still remains symptomatic, which is acknowledging the cause and treating for that. I think that should answer, not to get panicked too much about whether I had COVID or I didn't have COVID. If you develop any symptoms, people have to see down the time, we need to take a decision how to address these type of acute phase stress disorders. I think that should answer your question, Jackie. Thank you. Thanks a lot.
Thank you, sir. Thank you so much for addressing this nice question with a lot of hypotheses going on, and you addressed all the hypotheses so nicely. Thank you, sir. So my next question is to Dr. Shubharit. Can Parkinson's disease affect the young? And is there any difference in symptoms between the young Parkinson patients and the older patients with Parkinson?
Hi, Jackie. Am I audible now?
Yes, Shubharit, you are.
Okay. Thanks, Jackie, for this nice question. And thanks the organizer for this nice program for the caregivers and Parkinson's disease patients. So yes, Parkinson's disease can affect young people. What is the definition of young onset Parkinson's disease? Roughly, if the disease or the motor symptoms start in people who are less than 50 years old, it's known as young onset Parkinson's disease. If the symptoms start less than 20 years of age, then we like to call it a juvenile onset Parkinson's disease. When you type out Parkinson's disease in Google, often a picture of an old man with stoop posture, a tremor in hands, and freezing is shown. A picture, a sketch made by a famous neurologist is shown. But in truth, Parkinson's disease can affect a lot of young people. In fact, in India, we do see a lot of young people in the age between 50 to 60 years having between 40 and 50 years having symptoms of Parkinson's disease. So what are the difference between these people versus people who are older than 50 years of age? So there's some differences in the motor symptoms. So patients in general commonly have commonly have rigidity, and they may also have dystonia during the presentation. Dystonia means an abnormal, sustained or intermittent posturing of body part. So usually the leg is involved in Parkinson's disease first. So this posturing can be there while walking or while doing some exercise at the onset, and then it becomes more evident in walking, and then other symptoms like slowness, stiffness, tremor appear, and then patients usually get a diagnosis of Parkinson's disease. But in the beginning, dystonia can be a prominent symptom of Parkinson's disease, especially if it involves the lower limb. Then a patient of young onset Parkinson's disease can have a very similar presentation to late onset Parkinson's disease with all the characteristic features like rest tremor, stiffness or rigidity, and slowness of movements, similar to late onset Parkinson's disease. Usually, young onset Parkinson's disease patients will have a lot of painful cramps. The restless leg syndrome is more common in young onset Parkinson's disease, and some non-motor features like depression, anxiety, panic attacks, and tendency to develop some impulse control disorders are more common in younger onset Parkinson's disease. A younger onset Parkinson's disease is a risk factor of developing levodopa-induced motor complications. So over the course of 5 years, about 50% of the patients may develop levodopa-induced dyskinesia. So this can pose a treatment challenge. A lot of patients have this phobia of starting the drug levodopa and increasing the dose of levodopa. But recent studies have shown that by delaying this treatment in patients of Parkinson's disease, you do not necessarily delay the dyskinesia. Then if needed, to control the motor symptoms, levodopa can be started, but usually the doctors prefer other agents like dopamine agonists, and in some cases of prominent tremor, trihexyphenidyl. So there are a lot of treatment challenges in younger people with Parkinson's disease. In general, people who have young onset of symptoms have slow progression, they have less comorbid conditions, and they have less of axial symptoms like freezing and speech abnormalities and swallowing abnormalities in general. But many patients with young onset Parkinson's disease will have some form of genetic Parkinson's disease, like mutations in certain genes causing Parkinson's disease, and the type of genetic abnormality will influence the presentation, will influence the development of motor and non-motor symptoms. So these are some differences in general, but there can be a lot of differences based on what genetic abnormality you are carrying. Younger onset Parkinson's disease patients may have a poor quality of life because of the physical, psychological consequences of having the diagnosis of Parkinson's disease. So it poses a separate challenge. The treatment poses a separate challenge, but also it gives an opportunity for the clinicians to emphasize on lifestyle modifications, emphasize the role of exercise, physiotherapy, so that overall quality of health improves in those patients, and you can prevent certain comorbid conditions by adopting such healthy lifestyle. So I think this is my view on young onset Parkinson's.
Thank you, Shori. Thank you so much. You nicely highlighted all the possible differences. And now we will move on to the next question to Dr. Bhaskar Ghosh sir. My doctor has diagnosed me with Parkinson's disease, but my MRI brain is normal. Am I really having Parkinson's disease? I have also heard of some special dopamine brain scan to confirm if I really have Parkinson's disease or not. Do I need to do it? How it will help me?
Yeah, thank you, Jackie. Your question has two parts. First of all, whether an MRI should be normal in case of Parkinson's disease. Yes, as in the first lecture, Dr. Rishikesh Kumar has nicely described that Parkinson's disease is basically diagnosed based on clinical finding, that is mostly unilateral to start with, and there is slowness or bradykinesia accompanied by rest tremor, rigidity, postural instability. So if you have that symptom, classically, we clinically diagnose idiopathic Parkinson's disease. But we many a time we advise an MRI scan, although it is normal, but you know it's the initial part of the disease or in the latter part of the disease. Whenever we get it, one scan will help you to rule out some other abnormalities, like whether there is any hydrocephalus, whether any tumor or a stroke like lacunar infarct, or patient of vascular Parkinsonism, like that. So there are certain things which we need to look out, but it is not necessary if a classical symptoms of idiopathic Parkinson's disease is there. As far as MRI is concerned, the routine MRI is obviously normal in idiopathic Parkinson's disease. But if you go for some special sequences like iron sensitive MRI, you may get some loss of dorsolateral nagral hyperintensity. So because nagral cells have a lot of pigmentation, so this hyperintensity loss can be a finding. But these are especially well seen in 7 Tesla MRI. So these are at experimental stage. For practical purposes, routine MRI in idiopathic Parkinson's disease is normal. Now, coming to the second part of your question, that whether any dopamine DAT scan or dopamine transporter scan is required for diagnosis of Parkinson's disease. That I also tell you, if you have any doubt regarding your diagnosis about idiopathic Parkinson's disease, you may need it. But as per my thinking, it is mostly helpful in some cases of advanced essential tremor, where they have a lot of tremor at rest also and on action also, and they develop certain slowness. And if you give levodopa, they also do not respond. So whether you are really dealing with an advanced essential tremor or a Parkinson's disease, that is one aspect you can differentiate. Sometimes you can get vascular Parkinsonism. So if you get this DAT scan positive, that means patient may have either idiopathic Parkinson's disease, or these patients, this group of patients may respond to levodopa also. So this is one area. And also in some cases, as Dr. Charu has already nicely mentioned, that this is drug-induced Parkinsonism, where not that all the patients will just improve after you stop the drug. And we have sometimes we cannot decide whether you are really doing a case of idiopathic Parkinson's disease or a drug-induced Parkinsonism. In that cases, I think this dopamine transporter scan may help you. This is number one. And number two, if you have a idiopathic Parkinson's disease, this is one of the biomarkers. So if you can assess that how over the course of the time this transporter scan is responding, so that you can get an idea the rate of progress of the disease. But as you have already told, that just for routine diagnosis of idiopathic Parkinson's disease, I think this scan is not recommended, unless and until you have this following thinking on the back of your mind.
Thank you, sir. Thank you. So nicely you described when MRI is needed or when DAT scan is needed. Thank you, sir. So my next question is to Dr. Charulata Sankla, ma'am. Can you, ma'am, briefly describe what is atypical Parkinsonism and how is it different from having typical Parkinson's disease?
So first, let me just define the typical Parkinson's disease. So when there is a typical Parkinson's disease, you commonly see the resting tremor, which is a coarse tremor, which comes when you are not doing any activity, you're watching the television or you're walking, and that's when the tremor comes. And that's a very typical of the Parkinson's disease. This tremor usually disappears when you hold your hands in front of you, and then it comes back. But atypical Parkinson's, and this is the Parkinson's disease that is shows very good response to the tablet levodopa that you take for treatment of the Parkinson's disease. The atypical Parkinson's disease is when you start seeing some of the symptoms which should alarm you that you're not dealing with this levodopa responsive tremor containing Parkinson's disease. So we are looking at something else. So the red flags are when you start falling within the first year of the diagnosis, when you have very prominent autonomic symptoms, such as urinary incontinence, when you start having difficulty in remembering things, cognition changes. And these are some of the symptoms that will alarm you that you are dealing with something which is not atypical, where you are going to have a good response to levodopa, you are going to have a good response to the deep brain stimulation. It's not that kind of a Parkinson's disease. So early falls, autonomic nervous system disturbances, difficulty in remembering things, cognitive changes. These are some of the alarming factors that will tell you that you're not dealing with the typical Parkinson's disease. Typical Parkinson's patients also have, they talk in the sleep, they have difficulty in smelling, they have prominent non-motor symptoms, whereas these atypical Parkinson's disease have different kind of non-motor symptoms. They may not have these sleep disturbances, and they have urinary incontinence, they have fecal incontinence, they have postural hypertension. So these are, they have very low volume of the speech and very marked mask-like face that you see. At that time, you start suspecting. They may have early difficulty in swallowing, early difficulty in speaking clearly. Early falls is one of the really symptoms that I look for. And if they report early falls, then I would think of atypical Parkinson's disease. And there are certain clinical features that we look at which confirm the diagnosis of atypical Parkinson's, like PSP, CBS, diffuse Lewy body disease. These are the types of the atypical Parkinson's disease.
Thank you so much, ma'am, for you describe all those important red flags and give the clues when we will suspect that this is maybe an atypical Parkinsonism, not the typical Parkinson's disease. Thank you, ma'am. So my next question is to Dr. Prashant, sir. Can I develop Parkinson's disease even if there is no significant family history?
Yes. If you ask me, Jackie, this is the question which every person coming or every patient with Parkinson's disease coming, I have the same question. Why did I develop Parkinson's disease? None of my family members had Parkinson's disease. Forget about anyone in the family. Not even in my vicinity, in my area, in my village, or in my town, I know who is having Parkinson's disease. Many times, this is the question what they come to us. So this per se indicate, when they come and ask you that, this per se indicate that even if you don't have any symptoms, or if you don't have any family history or genetics is there, probability of you developing Parkinson's disease is there. So the question comes is, who are at risk? What can I develop it? What are the genes associated? So if you take about 100 people with Parkinson's disease, when you look into it, about 5 to 10% of the people have monogenic risk disorders. Monogenic means there is one gene is associated, where you check those gene, it's positive, they'll most likely develop the disease. Okay, and these are very small subset of the disease. So currently there are only few genes which we call it as a monogenic disorders are there, which we clearly know that if you have this gene in your family, you will develop Parkinson's disease, like your father had, your uncle had, or your grandmother had, grandfather had, and they may cause Parkinson's disease. However, in addition to this, there are a lot of things, that means about 80 to 90% of the people who have, we don't know why they develop. So in those set of patients, we are looking at a different type of a genetic risk factors, what we call it as. Means it's not one gene which is causing. There's some error or some type of a dysfunction in one type of a gene. There's some other type of a dysfunction in another type of a gene. And all these things are slowly adding up over a period of time. And when these are adding up, they increase the risk. So currently, we have come up with a concept called as polygenic risk scores, or PRS scores, what we call it as. Here, they look into different types of mutations which are happening in our body. If you have a combination of all these type of a small mutation, there's a probability of you developing a Parkinson's disease could be there. But in general, what I can tell is that isolated high-risk genetic risk factors are very small and can happen when we know clearly there is family history is there and you know the genes which are associated with the family. But about 90 to 95% of the patients most commonly don't know why they have happened or what type of genetic risk factors they had. They don't know about it. That is where the limitations is that. So this is what we need to understand. And many times when you speak to the people, like it's a genetic disorder or you had a risk to develop it, doesn't mean that everyone in the family should develop it. It means that you had more higher risk to develop it. So it varies from person to person associated with multiple genetic risk factors which combine together. And then we have epigenetic, means you have genetic risk factors, then there is outside risk factors such as like Dr. Bhaskar Ghosh told about exposure to toxins, pesticides. Similarly, there are multiple other which you call it as epigenetic risk factors. When they combine together, a propensity to develop Parkinson's disease will occur. So probably your doctor would be in a much better position to tell you based upon what type of family history you have, what type of risk factors you have, and whether there's a probability of you developing Parkinson's disease or not. Thank you.
Thank you, sir. Thank you. You brilliantly described all those links between the genetic factor and the environmental factor. Thank you, sir. So my next question is to Dr. Shubhori. I am 46-year-old and have recently developed Parkinson's disease. My doctor has ordered a genetic test. How the genetic test result can help in the diagnosis and management of my Parkinson's disease?
So the first, there are a lot of questions in this. So for a 46-year-old patient, who is, we can tell that he is a case of young onset Parkinson's disease. Okay, a doctor can recommend a genetic test after having a discussion on the utility of the genetic test for the patient. Number one, the genetic test does not help at all in the diagnosis of Parkinson's disease. Parkinson's disease is diagnosed clinically by the typical symptoms and signs that are there in a patient. So there's no blood test, no scans that will tell for sure that a patient has Parkinson's disease. Is the signs, symptoms and signs, and the progression and response to medications that will these things will tell us if the patient has likely Parkinson's disease or not. So no. So when a genetic test is ordered, it is ordered in different scenarios. So sometimes it is ordered in a research setting to test some hypothesis, or if we want to try out some drugs which can slow the progression of Parkinson's disease. These drugs are known as disease-modifying therapy. If you want to test these drugs, then the genetic test is important. Suppose you want to undergo some advanced form of treatment, like surgical treatment, like deep brain stimulation. Sometimes the genetic test can help you prognosticate whether the patients will respond well to deep brain stimulation or not. So for prognosis and in research setting, to test some hypothesis, to try out some disease modifying therapy in clinical trials, you may order a genetic test. And if there is enough family history of Parkinson's disease, then you can offer a genetic test, and the results of this genetic test will help in the prognosis, will help in family planning, will help in financial planning, and will empower the patient more. But there are a lot of consequences of knowing the genetic test. So a proper pre-test counseling and a post-test counseling is needed to really know whether a genetic test is beneficial for the patient or not, and how the patient will take it.
Thank you. Thank you, Subari. You discussed all the pros and cons of those doing or not ordering genetic test. So with this, we'll conclude our panel discussion 1, and we'll move on to the panel discussion 2. I will welcome Dr. Pankaj sir to welcome all the panelists and proceed. Thank you.
Thanks.
Okay, thank you. I think, thank you, Jackie. That was a very informative session, and I would like to thank again all the 4 panelists who have answered all the questions very, very well and in great detail. So Dr. Charu, Dr. Prashant, Dr. Suvarit, and Dr. Bhaskar Ghosh. So thank you again. And I think our listeners will have gained a lot of insights, and many of their doubts will have been answered. So now it is time to move on to the other panel discussion on the management of Parkinson's disease. So we know that there is medical management and drugs and even surgery or deep brain stimulation, and importantly, lifestyle modifications. So we will ask questions to our 4 panelists. So I would like to welcome Dr. Mohit Bhatt from Mumbai, from the Kokilaben Hospital. So welcome, sir. And Dr. Achal Srivastav from All India Institute of Medical Science in New Delhi. So welcome, sir. Dr. Petras Vardia, my colleague here in Mumbai at Jaspur Hospital. And Dr. Mitesh Chandrana from Gujarat. So I would like to welcome all the panelists here, and maybe we can start the questions. So first I would like to ask Dr. Achal Srivastav, sir, maybe we will start with the medical management of Parkinson's disease first. So again, from the point of view of a patient, the patient is asking, sir, is Parkinson's disease curable? And do I need to continue this medication for lifelong?
Okay. The question is very important, and from the patient point of view, basically, and all of them want to know whether the life is whether they need to continue treatment throughout life, and the other one whether it is curable. Of course, it is not curable, not a curable disease, but I will say that to much extent we can manage most of the symptoms for many years. So in that sense, it is, somewhat more manageable disease than other neurodegenerative conditions. And number two, of course, the treatment has to be continued for a long period of time, maybe throughout life.
Okay. So basically treatment is lifelong. Yes. So thank you, sir. Also, can you also answer this? That one patient has asked that I am having early Parkinson's and I am nervous about starting levodopa right now. And someone has told me that it can create a lot of side effects in the long term. And I'm afraid of this medicine. Am I correct in wanting to delay starting this medicine for Parkinson's?
So this is like there has been so many studies in this regard, particularly whether delaying the treatment is good or whether early start of with levodopa is good. So the answer is not one. I will say that there is a preference to dopamine agonist in the early part of illness, and then of course then we can add later levodopa carbidopa combination. And of course in the younger age group we can use trihexyphenidyl as well. In the younger age group, but it all depends on how fast the disease is progressing, depending on the type of disease, type of mutation or whatever the patient is having. So accordingly, the decision may be taken whether to start levodopa or not. However, it is still unclear whether to start levodopa early will harm him or not.
Okay, so thank you. Now I would like to ask Dr. Petrus Vadia. So Dr. Petrus, maybe you can unmute yourself. So the patient here is asking, I have been diagnosed with Parkinson's for the last few years and I am currently on levodopa. And my doctor has often asked me whether I have this thing called wearing off and whether I have this thing called dyskinesia. So what is the meaning of these things?
So I think in the initial phase, your levodopa effect lasts for many hours and many patients don't experience any wearing off. So the effect of the levodopa lasts for a long time. So you really don't realize before your next dose that your Parkinson's symptoms are coming up. But as the duration of Parkinson's disease increases, many patients will experience what is called as wearing off. Wearing off is basically where your Parkinson's symptoms subside after you've taken the dose, maybe half an hour to 45 minutes later, but reappear before the effect of the next dose kicks in. And when I say effect of the next dose kicks in, it also means that you might have taken a tablet of your levodopa, but the tablet of the levodopa takes about 30 to 45 minutes to reach the brain, depending on whether it's on empty stomach or on full stomach. So actually, you will notice the symptoms maybe 30 to 45, notice improvement 30 to 45 minutes after your tablet. So the symptoms can be, depending on every patient, is different. So your symptom could be the reappearance of tremors. Some people may become slow in their walking. Some people may have freezing of gait or shuffling when they're walking. So this is wearing off. Now, dyskinesias is a different issue. Dyskinesias can be of two types. They can be of peak dose dyskinesias. Usually they come with this kind of a rocking movement. It could be neck, it could be mouth, it could be upper limb movements. And these are usually at the peak of the levodopa effect. So they will come around usually an hour or hour and a half after you've taken your dose. And these are usually peak dose dyskinesias. As the disease advances, they may occur all the time. On the other hand, biphasic dyskinesias are much less common and they usually occur at the beginning of the dose, just as the dose is kicking in, or at the end of the dose, just as the dose is kicking off. And these are called as, and these usually come as lower limb dyskinesias and they occur with the leg rocking back and forth. And these are typical biphasic dyskinesias.
Okay, good. Thanks. So that is what these terms mean. And I think all Parkinson patients are familiar with these two things, wearing off and dyskinesia. So also, maybe I can ask you, what are the strategies that patients can follow, Dr. Petrus, that while taking their levodopa to maximize the efficacy of this medicine?
So I think the important thing is that levodopa works best when you're taking it on an empty stomach. So if you've taken it about 30 to 45 minutes, say up to an hour before a meal, you're much better off than if you've taken it on a full stomach. When you've taken a full stomach and a proteinaceous meal, the efficacy of levodopa is lower. It takes much longer to work. So I think the first thing is to take your medicines empty stomach. People generally have a tendency to take it after breakfast, after lunch, after dinner. That's probably not the best way because your levodopa is not going to work well. I think what you would realize is that levodopa works, say, 3, 4, 5 hours after you've taken it. So taking your last dose at 9 p.m. is probably not going to help you if you're going to go to sleep in an hour. So your dose should be timed as per your schedule. And it has to be tailor-made to the patient schedule. And that's what you need to discuss with your doctor also. So I think empty stomach and taking it in a schedule that works so that your day is better controlled. Because each person's wake-up time is different, their meal times are different. So your dose has to be tailored as per all these time schedules. And avoid protein in the daytime. Having a very high proteinaceous meal in the daytime, you often messes up your levodopa absorption. So everyone needs protein, but the protein then has to be moved more towards your nighttime meal rather than your daytime, so that your daytime is smooth and well controlled.
Right, thank you. So what you're saying is that empty stomach is better, and take it regularly as your doctor has advised, and avoid protein intake especially along with the tablet, and of course to take it regularly. So thank you, Dr. Wadia, for answering these questions. So I think as the disease progresses, I think there comes a time in Parkinson's when many patients will need some surgical treatments, and we heard some previous mention of this also. So there is a time when the medications do not act as well, and there are side effects, uncontrollable dyskinesia or dancing, and severe wearing off, and they cannot be adjusted anymore, with medical management. So at this time, the question of deep brain stimulation surgery arises. So I ask Dr. Mohit Bhatt that, sir, from the point of view of the patient, he is asking, when in my journey of Parkinson's disease should I undergo DBS surgery?
So DBS surgery is usually selected for patients who have had the disease for a substantial period of time. Mostly patient has had the disease for more than 5 years. It's actually a gut feeling of the treating neurologist. When you are treating a patient for many years, a stage comes in the patient's life when the neurologist starts feeling that the drugs are not doing an adequate job. Patient is running into problems. And I often tell patients that if you are 65-year-old, and if I have to ride you till you are 85, with your medical treatment, I may have difficulty sailing you till you are 85. And I have already planned a journey till you are 85 at least. So sometimes that is the time when I say that, well, you will require a surgical intervention so that your quality of life improves, your quantity of life improves. And that's exactly the indication for surgery, is to improve quality and quantity of life. Patients who run into where the drugs are not proving adequate to give them a good on so that they can live an independent life. Patients are having severe dyskinesia, which you cannot control with drugs, because the moment you reduce drugs to control dyskinesia, they go into a off state, and the off states increase. If you give them more medication, they are dyskinetic. So you are yo-yoing between an off stage and a dyskinetic stage. That is where surgical intervention is very effective. Patients who run into difficulty with drugs, you can't give drugs because they are hallucinating. They are running into problems related to dyskinesia, hallucinations, sometimes falls. So all these things where drug increment becomes difficult, that is the time when surgical intervention comes into play. Sometimes the surgical intervention is a planned process in the sense that when a neurologist has been treating a patient with Parkinson's disease, he can literally visualize that in a year or two, the patient may need surgery because the rate of progression of Parkinson's disease, the rate of progression of drugs has slowly increased. And that is the time when we do discuss with patients that you may need surgery, because that people also need time to prepare mentally, get ready for surgery mentally, physically, mentally, financially. So it's we do give a heads up to patients, sometimes well before the actual surgery.
Right.
I hope that answers the question.
So thank you, sir. So yes, very much so. So also, just to continue, many of our patients are very afraid, and when the word surgery is mentioned, they are naturally sort of very apprehensive, and they wonder about side effects of the surgery and whether they will tolerate it, or they worry about whether they will even die during the surgery. So, what would you like to tell patients who are advised DBS surgery after being, seen by their neurologist and he has advised them?
So this is the most challenging part, is to convince a patient to undergo surgery. If I was a patient and if I had to undergo brain surgery, I would be very nervous. And so I can fully understand that patients are nervous to undergo surgery. So usually we do sit down and we spend a lot of time reassuring the patients. And that helps when you are in a center where you are regularly doing surgery, so that you can confidently tell them that most of the patients do not experience any serious side effects. Chance of death during surgery, I have never had a single case. And I think it's extremely rare. I often explain to them the risk of crossing a road in Mumbai city or traveling by a rickshaw is a million times more than undergoing a surgery. So, or having a complication on the table. So that is number one. Number two, I do reassure them that this is an awake surgery. So most of the time, we do not give any anesthesia where the patient is unconscious. So patient is fully conscious, and this we can do because the surgery is painless. So emphasizing the painlessness of the surgery is very important, and that is the truth. We give little anesthesia to just put the electrodes in the brain, and we only need anesthesia when we are implanting the battery, which is for a very short period of time. So patients are fully awake during surgery. I also tell patients that often after surgery, by evening, you will be sitting up. And most of our patients, I would say 95% of patients, sit and have breakfast next day morning in their bed. And they are moving around mobile the very next day. So if this was a complicated, difficult, destructive surgery, that would not be possible. Chances of side effects, most people want to know. Infection, we have never had an infection. So sometimes the infection happens if the patient injures the site of the electrode and the wound is opened up, you can get an infection. But otherwise, in a controlled atmosphere like the operation theaters, chance of infection are rare. Hemorrhage in the brain, people do ask, chance of hemorrhage is 1%. So if you do 100 surgeries, one patient may have a hemorrhagic bleed. So that 1% is today in the scientific world an acceptable risk factor for any procedure. So it's a very safe surgery. It's a very effective surgery. It's also life-changing surgery. Patients with Parkinson's disease, when they are operated, they are at a stage. I always tell my patients that after I have done the surgery, you will tell me that I wish I had had the surgery 2 years back, because the quality of life improves so much. Patients who are losing weight put on weight, their well-being improves, they look better, their dyskinesia gets controlled. So to go through all these things, it requires time. So you need to have a setup where you are going to spend 1.5 hours with a patient explaining all this to convince them that surgery is good for them.
So what symptoms can be expected to be better, and what symptoms may not be so much better after DBS surgery?
So some of the symptoms that improve clearly after surgery is patients who are losing weight start putting on weight. So the sense of well-being improves. Those who are dyskinetic, the dyskinesia goes away because 50% of the drugs get less. So patients feel very happy when they are taking less medication. So on time improves. So they are now more on. If they have aches and pains because of Parkinson's disease, they go away. Tremor improves dramatically. It literally melts away. So the tremor improves. Their ability to maneuver themselves in bed, turning in bed, getting up from a chair improves after surgery. And their on time improves. The offs are not so debilitating as they are before surgery. So the overall quality of life improves. What does not improve is if patients have speech problem, the speech problem may remain. Sometimes the speech problem can even worsen after surgery. So that is one thing that we do tell patients, that speech problem may not improve. The other thing is if patients have freezing of gait, where the legs get stuck to the ground. Now, freezing of gait, if it improves when you give levodopa medication, then it will improve after surgery. But freezing of gait, which does not improve with medication, may not improve after surgery. So these are very clearly finite things that improve and they don't improve.
Thank you, sir. I think that was quite comprehensive about deep brain stimulation. And one other related question, maybe I can ask you, Dr. Bhatt.
Yes.
Is there any other advanced therapy that is available in India for Parkinson's?
Well, there are other treatment available. People use apomorphine. Apomorphine pump is available. Apomorphine injections are available. Apomorphine is a very short-acting drug. It gives you an on for a very short period of time. And but if you have a continuous pump, then you get continuous apomorphine. The problem with apomorphine is that it produces substantial nausea and vomiting. So you have to get used to it. You need added medication to prevent nausea and vomiting. The other advanced treatment for Parkinson's disease is, it's not for Parkinson's disease, it's for tremor, is MR-guided stereotactic surgery, where MR-guided stereotactic surgery is useful for tremors. But the unfortunate thing is that it can only be done on one side. We cannot do it on both the sides. There are very few selected cases where you can do it bilaterally, but otherwise, so tremor-dominant Parkinson's disease, MR-guided stereotactic surgery is also available in India.
Right. So out of all the advanced therapies, I think which one do you think would you prefer? And of course, it is case to case, but which one do you think,
Yeah. So of all the therapies, I think I would opt for deep brain stimulation surgery. The reason being that this surgery is, it's like you can tailor the surgery. You can increase the current in the brain. You can reduce the current. So you can reduce the symptoms on right side, left side. So you can have very focused therapy for individual part of the brain. So you can put the settings in the battery in such a way that you can reduce the tremor, you can reduce dyskinesia. So you have a far more control over your brain cells while using with DBS. Again, DBS, the batteries have a life of now 25 years, so you don't have to really go back and forth with the surgery once you've done the surgery. And the experience world over is of millions of patients who have been operated and who have been published. It shows that DBS is a very effective treatment. With apomorphine, there are side effects to apomorphine. I don't think there's a cost saving with apomorphine. And it's a very simplistic treatment. It just gives you an on. While you can't do fine tuning of different symptoms with apomorphine. As far as the focused MRI is concerned, it's mainly used for tremor dominant symptoms. Again, you are making a hole in the brain. And once you've done it, it's done it. You cannot alter it. You can't change it. It's a small little lesion in the brain, while deep brain stimulation is not a destructive surgery.
Right. So thank you, Dr. Bhatt, for your views. I think we will move on to some more questions. And Dr. Mitesh Chandrana, movement disorder specialist from Gujarat, is here with us. And maybe I can ask him. One of the most common questions that patients ask us in the clinic is, what should I eat? And how should I modify my diet? What food should I have? So what would you say, what dietary modification strategies should one use in Parkinson's?
Yeah, So, as you rightly said, because it's a very important question. So, overall, I would say there is not a single dietary plan which is recommended for Parkinson disease. So, I would advise that overall that the patients can take overall balanced diet, but there are certain dietary modifications that can be helpful to alleviate different, like particularly symptoms like for constipation. Those patients, Parkinson disease patient who have constipation, can take a high fiber diet. Inclusive of lots of fruits, whole grains, vegetables, as well as they should take more amount of water throughout the day. Apart so that this kind of strategy can help in alleviating or reducing the constipation, increasing the drug absorption. The second thing, in perspective of neuroprotective part, till now there have been a lot of research studies are there in the literature, but not a single study has shown that any particular one food that has shown a neuroprotective effect. But there are certain foods which are high in antioxidants, like nuts, like walnuts, pistachio, berries, various kind of berries, dark chocolates, green leafy vegetables. These are foods which are higher, which have high amount of antioxidants. So that can lead to help in alleviating oxidative stress, which is one of the proven pathophysiological mechanism of Parkinson disease. And apart from that, there have been a lot of research in foods rich in omega-3 fatty acids like soybeans or flax seeds or kidney beans or even salmon. So this also can be considered, but not a proven role yet. And there are certain food which patients of Parkinson disease should avoid. Like one particular thing, Dr. Petraswadia mentioned that patients should avoid high protein meals during the daytime because it affects the absorption of levodopa carbidopa, which is the most important medication in patients with Parkinson disease. Apart from that, patients should avoid food with high saturated fat as well as those foods which are hard to chew because patients with advanced PD have difficulty in swallowing as well as chewing. And during night time, before going to bed, patients also should avoid certain caffeinaceous food or alcohol, as well as patients should avoid high sugar food because it can interrupt patient's sleep. So ultimately, it affects the quality of life of patients.
Yeah, no, very good. And I think that was quite comprehensive. So I think one of the other questions is about exercise and the role of physiotherapy in Parkinson's. We know it has a huge role. And so we tell all our patients to exercise. So what is the role of physical exercise and physiotherapy in Parkinson's?
Yeah. So I think as we discuss management of Parkinson disease, apart from medical as well as surgical treatment, this is a third and equally important part for patients with Parkinson disease because it improves both physical as well as mental health of patients with PD. So in particular, if we discuss one by one symptoms, so patients with Parkinson disease have stiffness, rigidity. So by doing physiotherapy, it helps in improving the flexibility as well as range of movement at various joints. Second thing, patients with advanced Parkinson's disease have more gait dysfunction in form of freezing of gait, balance issues, risk of falls. So physiotherapy for gait, particularly for gait and balance training, it improves the overall mobility as well as balance and it decreases the risk of falls. Apart from that, muscle strengthening exercises can also help in improving the posture of the Parkinson disease patient. Advanced PD patients have flex-to posture. So by strengthening the core muscles, it improves the posture of the patient. And ultimately, due to this motor symptoms like stiffness and dystonia in Parkinson disease patients, they have pain. So by doing physiotherapy as well as regular exercises, that can help alleviating the pain related to the stiffness or dystonia. And there are various modalities for exercise for gait freezing like sensory cueing, balance training, individual activation, observation training. There are various physiotherapy. And ultimately, all of these strategies helps in improving quality of life as well as increasing the functional ability of the patient.
Thank you, Mitesh. And maybe I can also ask on the role of a lot of patients of Parkinson's have difficulty with speech and swallowing. So I think these are very important issues. So what is the role of a speech and swallowing therapist in the life of a patient with Parkinson's?
Yeah. So this role of speech and swallow therapy is particularly very important in the later patients with later stage of Parkinson disease, because speech and swallowing are more affected towards the later stages. So ultimately, by doing speech therapy with a specialist in the speech and language, it improves the quality of life. Plus, it improves the communication with caregivers. So ultimately, it leads to improvement in disability as well as improvement in quality of life. Particularly recommended speech therapy is Lee Silverman voice training. Ultimately, so by that method, it improves the clarity of speech as well as loudness of speech. And if we talk about swallowing therapy, so swallowing therapy, what they do, that they strengthen the muscles which are used in coughing, swallowing, breathing, as well as speaking. By doing that it improves the swallowing of the patient, and ultimately it leads to improvement in disability related to swallowing.
Okay, so thanks, Dr. Mitesh, and these are all important issues in the life of patients with Parkinson. So I think we had a nice overview by Dr. Achal on levodopa and some doubts regarding that. Dr. Wadia on medications and how to take them without food and protein, avoiding protein, etc. Dr. Bhatt on deep brain stimulation and its role and how it changes lives, and some questions about that. And of course, some lifestyle tips, very important, by Dr. Mitesh on exercise and speech and swallowing. So I think we had quite a nice session. I think you will all agree. Let us just look at, we have some 10 to 15 minutes more. So let us look at some questions in the chat box. So Jackie, are there any questions that you would like to maybe ask?
Yeah, so most of the questions are actually already answered by our panelist, by Shubharit. Some I answered, Rukmini ma'am answered some questions. So a lot of questions are coming related to protein, like milk and other protein products, as we already discussed this, like 1 hour gap was discussed that can hamper, protein can hamper the absorption of levodopa. So there are 2-3 questions I am seeing on that.
Yes. So do you want to go ahead and ask one of the panelists?
Yeah. So I am seeing which are the questions. Mostly they have answered all these questions what I am seeing. So one question was with the weight loss. And Mitesh, do you want to take up that question regarding the nutrition weight loss?
Yes. What is the question?
So question was, what is the link between the weight loss and Parkinson's disease?
Yeah. I think Dr. Mohit sir nicely described that weight loss actually happens more in advanced Parkinson disease, particularly because of motor disability, like because of severe stiffness as well as dyskinesia. It can lead to increased energy loss, and ultimately it leads to weight loss. But there is no direct link between the disease pathology as well as weight loss or gain in particular. And due to same, after DBS, as sir discussed, after DBS, the stiffness reduces and dyskinesia goes away. So patients gradually start gaining the lost weight immediately after surgery, particularly in the first year post-surgery.
Thank you, Mitesh. So some questions are coming up here regarding memory cognitive decline progression based on the stages of Parkinson. I think Rukmini ma'am can answer this question on the cognitive decline progression on the stages of Parkinson.
The Parkinson's disease, I mean, stages is based upon the Honeyard scoring, so which is not really immediately directly correlated with the memory loss. So memory loss has got a lot of factors which come in. So one is the duration of the disease. So the duration of disease definitely makes a role play. I mean, if it's like more than 10 years or 15 years down the line, patients tend to have a little bit of memory loss. The other main important factor is the age of the patient. So the age at the onset of the patient makes a lot of difference. So what people are realizing now more and more is it that the older age is the main contributing factor rather than the duration of the disease itself. So whether you have the disease in 30s or you have the disease at 60s, you probably will have memory loss somewhere around 65s and 70s. So because that, so that is, so if you have a younger onset PD, you don't need to worry so much. You still probably will have a long life before you can develop cognitive impairment. Older people, on the other hand, tend to have more cognitive impairment. The type of disturbances that you have also makes a difference. So the subtypes definitely play a role. People who have a tremor predominant Parkinson's disease tend to have a little lesser memory loss compared to those who have an akinetic rigid state. People who have got more great freezing tend to have more cognitive impairment. So these are some combinations which happen, and probably that there is a genetic basis to it. So some of the genes predispose to more memory impairment compared to those, I mean, some of the other genes like Parkin and all, which Parkin, LRRK2, they have lesser chances of developing cognitive impairment. GBA mutations have more chances of developing memory impairment. So these are something which do help. But what I would suggest is that having a very active cognitive rehabilitation therapy or keeping yourself mentally active is one, and physically active is one of the way to delay the progression or onset of cognitive impairment.
Thank you. Thank you. So 2 questions I am seeing on pranayam. So some specific exercise, whether pranayam will help or not.
So definitely, yes, this modes of exercise like yoga and pranayam can help in form of improving the posture, overall posture of the patient, as well as improves the flexibility as well as range of movement and muscle flexibility. So in that, definitely it helps overall then rather than doing no exercise.
Thank you, Mitesh. So a nice question has come up. So I just want to know the role of support group in management of Parkinson's disease. I think any of our esteemed panelists can take up the question.
So maybe I can ask Dr. Petrus Vadia to answer. Are there any support groups in the management of Parkinson's?
So I think there are a fair amount of
Which will
support
help,
groups. A lot of so PDMDS is one big support group which is there and has got multiple centers, both online and offline format. Basically, I think the support groups help in the way that you first realize that you're not alone in this fight for Parkinson's, because which is a big question. Why me? Why did I get Parkinson's? So I think this feeling that you are not the only one is a very important thing. And a lot of people who eventually have got over that inertia and gone to a support group have actually said that, thank God I got Parkinson and I never entered the support group. So I think support groups do play a major role on the emotional side. They provide physiotherapy, they provide cognitive therapy. And I think also most important is the sense of emotional well-being.
Thank you. Thank you.
No, thank you. Great. So maybe I can take the liberty of asking some of our most senior panelists on maybe I can ask Dr. Charu. So, ma'am, what tips would you like to give in general to your patients with Parkinson's to lead their lives? Anything that you want to tell? So is Dr. Charu there? Okay, so maybe I can ask Dr. Achal Srivastav. Is sir there? Can you hear me?
Yes.
Yeah, sir. So, in general, would you like to give just some summary tips to your patients with Parkinson's? So, how just some tips on how you would like them, things to remember on a day-to-day basis, just in general. So, Dr. Bhaskar Ghosh, Dr. Mohit,
Yeah,
anybody can take that.
Yeah, and I'm audible?
Yes, sir.
Okay.
Yes.
Okay. So I would say to my Parkinson disease patient that although disease is not curable, like diabetes, hypertension, asthma, like that. So it is mostly nowadays it is a symptomatic treatment. So they should continue the drugs as prescribed by the doctors, because sudden stoppage or withdrawal of the drug may precipitate certain complications. So they should regularly take up the drug. They should report to the doctor any adverse effect or any hallucination or any dyskinesia or off phenomenon. If they record, they should report to the patient, and they should follow the advices given by the doctors regarding food, as already been discussed, and regular physical activity. So that is the most important part. And it has to be remembered that as long as they will continue the physical activity, they will do better. It is not that if they stop it, it will continue to benefit, but they should continue their physical activity. They should avoid stress. They should, whenever they attend any hospital or any new doctor, they should carry the prescription of the neurologist that he is on these drugs. Otherwise, there may be a lot of complications. And with this advice, they can remain very good for their disease.
Okay, thank you, sir. Maybe I can ask Dr. Bhatt. So, any message you would like to give patients in general on the occasion of World Parkinson's Day?
Well, there are a couple of things that comes to my mind. First of all, I would tell patients with Parkinson's disease that there's a great hope for them. This is not a disease like cancer. This is not a disease. If they have blood hypertension or diabetes, I tell them those are worse disease than Parkinson's disease. Though Parkinson's disease is obvious, visible, and diabetes invisible, diabetes is known as a silent killer. So I tell my patient that if you have blood pressure, you have diabetes, even if you don't come to see me and miss my appointment, that's okay, but do not miss the appointment of your diabetologist, your hypertensive doctor. So looking after your general care, looking after your other illnesses is extremely, extremely important for patients with Parkinson's disease. Second thing that I tell patients is that this is a journey that we are going to travel together. And we are here as doctors. Today's day and age, there is so much of development, there's so much of research. There are so many movement disorder doctors now in India who are really good experts in dealing with Parkinson's disease. So there is no dearth of expertise. You are fortunate that you are in India. We have most of the drugs available that are available anywhere in the world at 1/8 or 1/10 the price. So medical treatment is cheap, medical treatment is available. There are experts to deliver that care. So today surgical treatment is available, all the drugs are available, so there's great hope. So hope is something that we need to tell patients and give them that hope. And that is the truth. That is the fact. Parkinson's disease is the first neurodegenerative disease of the brain, which is treatable. This is the first disease that was the treatment was discovered in 1960. Since then, multiple drugs have come into use. The third thing that I tell patients is exercise is very important. They must exercise, they must remain fit, they must remain well, physically, mentally, emotionally. And the most important thing is the role of so I don't like to see a patient with Parkinson's disease alone. If they come alone, I say, please next time bring your family, bring your spouse, because the role of the spouse, role of the partner, role of children is very important. Emotional bonding, looking after the care of the person whose needs may increase with time is very important. The family must be sensitized, must be sensitive to the need of the patients, and that greatly helps looking after patient with Parkinson's. And of course, lay societies where there are other patients where they can exchange notes, they can exchange information, they can exercise together, and a sense of a community. You know that you are not alone. There are others with Parkinson's disease, there are others who are battling the same disease and still coming victorious. So victory in Parkinson's disease is a must today. Today is a day when we have to think that we have conquered a disease which was not curable 100 years ago.
Yeah, no, that is a wonderful message. And, I would really appreciate the fact that you have brought this, and it really feels us all providing care, for patients with Parkinson's, and we are also enthused listening to these positive messages. So maybe before the close, I can ask Dr. Achal sir, if you have any few words to tell your patients with Parkinson's, the entire audience, What would you like to tell them today?
Just few things and very important things. One is that they should follow the physician's advice. Neurophysician, whosoever is seeing, must follow the advice. And number two is exercises. They should not stop walking. I must say that once they stop walking, they will never walk. They should keep on walking.
That's great. So, anybody else on the panel? I would like to invite if you have any comments or questions before we ask the president, Dr. Asha Kishore, to say her final words, maybe. So anybody would like to comment?
There are a few more questions that we can see in the chat. Is there anything important that we have missed out?
Most of
Try to just take most of them, and
yeah, I think most have been answered. Yes.
Pankaj sir, somebody has asked about the sleep, like importance of sleep and how much one should actually sleep for inpatient. Like I think this question has not been answered.
So maybe we can ask Dr. Rukmini. Yeah, Dr. Rukmini had some information in the slides. So
yeah, I think sleep is
again. Rukmini, would you like to please answer?
Yeah, so how much sleep is required? 6 to 8 hours of sleep is considered normal for everyone. Some people tend to sleep more, some people tend to sleep less. So the idea is that after a good sleep, you're supposed to feel awake and energetic and not sleepy the whole day. So that's how you know how much sleep you require. Not everybody has the same amount of requirement, but that 6 to 8 hours of sleep is required per day. So, I think...
Oh, great. It is extremely important. Okay, so I think if there are no more questions, maybe I can ask the president, Dr. Asha Kishore, madam, to please say a few final words.
I think I would like to first thank the participants who have stayed long for 2 hours and asked a lot of relevant questions that are important from the patient's point of view. I'd like to congratulate all the speakers also for giving them very pointed replies to very pertinent questions that were asked, and also for Pankaj and Jackie, who have conducted this session very well. The messages from the senior movement disorder specialists were also very important. What Mohit Bhatt has highlighted, I think, is the big message that there is a lot of hope. And I keep telling my patients that, all of us would wish, we would never get any disease. But if we are destined to get a neurodegenerative disease, I would myself personally wish for Parkinson's disease, because this is something can be treated for very long periods of time. I tell my patients that nothing has ended. Their life has to continue. They can keep working for as long as possible. And we would be helping with the usage of appropriate medications. Now, DBS has made a big difference. A lot of people, particularly young people with Parkinson's disease, can return to their previous jobs and have their normal social life. Now, a lot of people travel, they enjoy social life, and they enjoy better relations because of these advents in therapy. And as Mohit said, 50 years ago, 100 years ago, we never had a therapy. Then came levodopa that made a huge difference. Then we ran into problems with the medication. Now, DBS has given a second lease of life to a lot of patients. So there is considerable hope in the management of Parkinson's disease. Now, we have also this major challenge of taking care of the non-motor symptoms. It is very important that to know that none of us were aware of the importance of non-motor symptoms and how much it impacted the lives of patients. Now, this has come to the forefront. As doctors, we have been able to sensitize ourselves and also inquire about these symptoms in patients and bring out these symptoms, because they never associate these with Parkinson's disease, because it's considered as a disease of movement, stiffness, slowness, balance problem, etc. But there are a number of non-motor symptoms associated with which can be, dug out from the history, and we can help the patients in a whole lot of ways. The importance of good diet, sleep, physical activity, remaining mentally active, socially active, and being occupied. These have been highlighted very well. The need for compliance with treatment, not mixing up different, methods of treatment and complicating their own treatment, self-treatment and changing prescriptions very often, this doctor shopping, etc. are perhaps avoided, and you can stick to a particular doctor. There are a number of neurologists with expertise in the management of Parkinson's disease, a number of movement disorder specialists who have, very good experience as well as expertise in the medical as well as surgical management. So treatment of Parkinson's disease has become actually very satisfying to the treating physicians, and it has brought a lot of changes in the lives of patients with Parkinson's disease. There's considerable hope. There is considerable advancements in this field and many more to come. So the future looks very bright. There can be, treatments that will delay the onset of disease in people who are predisposed, methods to detect who are all at risk, and also probably drugs that will prevent the progression of disease even if you have had it. So there is much to look forward to in the future, and a lot of things happening currently that can improve the quality of life of these patients. So we are all committed to this cause. We are here to support you. We are here as your advocates to make sure that you get the best of treatment, that there is uniform protocols for the management of this disease so that patients in no part of the country is deprived of the best of treatments available for this in our country. And things have changed so much. What we once thought was necessary, to go abroad to have a surgery or to get a certain kind of drug, now it is all possible here, right at your doorstep. Things have become more and more affordable. Medical insurance has come into the field in a big way that has made DBS also accessible to a lot of patients, affordable to a lot of patients. So there have been major strides made in the field of Parkinson's disease, and so there is much hope among the treating doctors, much things to hope for among patients and their caregivers. So I wish you all a wonderful, Parkinson's Day, even though it is belated, and we will all fight together and we will conquer this disease one day. Thank you.
Thank you. Thank you so much.
Thank you. I think that was a wonderful message. And I would like to reiterate to all the patients that as all our panelists, esteemed panelists have said, there is hope for patients with Parkinson's for you. If you're listening and if you have Parkinson's, there is excellent treatment, surgery, all specialists available everywhere in all parts of India. So we are all here to help you and you are not alone. So I think thank you very much to all of you for attending. Thank you to our esteemed panelists again for spending their time and giving this valuable message. And with all its nuances and all the details of various aspects of this disease, I would like to thank also my colleague, Dr. Jackie Ganguly, for excellently co-conducting and organizing this as well. And also thanks to the MDSI for conceptualizing and planning this program. So I think with this, we are out of time. So I think thank you very much and good night.
Good night.
Good night.
Thank you. Thank you.
Everybody.
Good night. Good to see you guys.
Thank you, sir. Thank you.